He's senior scientist at the Schroeder Arthritis Institute and the Krembil Research Institute. He's a professor of medicine at the University of Toronto, and he's globally recognized as a leader in lupus research. His accomplishments include publishing over 458 papers. He's trained more than 120 rheumatologists, and I would say he's probably trained about half of our Jeff Carr Fellows. And he's also received numerous awards from the American College of Rheumatology, the Canadian College of Rheumatology, and others. He began his research in 1970. So there's no one better to share with us this year the advances in research over the years. So I'm going to turn it over to Dr. Urowitz. Welcome, and thank you so much for being with us today.
Thank you, Linda. Can you hear me?
Yes, we can hear you.
You can see the screen?
We can see the screen.
Oh, great. Anyway, thank you very much. It's an absolute delight listening to all the work you're all doing. It's spectacular. When I think of where we've come from over the years, I think you're accomplishing tremendous advances, and I thank you all for it. And I'm sure benefiting all lupus patients everywhere. So anyway, it's a pleasure for me to be here. And you know, what I've done over the years is I've always tried to tell you of the kind of research that we're actually talking about, that we are presenting, work that we've done, that we're presenting at national meetings of rheumatologists and lupologists, if you like, around the world. And this will be no different. Today, I'm going to talk to you a little bit about what I'm going to be speaking about in a week from now to the Lupus Academy, which is it's a large number of lupus doctors from around the world, from Europe, Asia, North and South America, who gather together to discuss their research, present their research, and then where things might go in the near future. And so this is some of the work that I'm going to present to them. I'm glad that Kostas was here with us as well today, because Kostas joined us in this research. So Hamilton is just down the road, and you can continue to collaborate. So what I've decided to talk to you a little bit about today is the kidney problem. You know, kidney problems affect, and we'll talk about it in a moment, a significant number of patients with lupus, and it requires some special attention and special treatment and patient cooperation. And I'm going to try and stress of all of those things today as to where we are and where I hope that we're going to be going in the not too distant future. So, by the way, you're hearing this before the Lupus Academy. So remember, this is still secret until after my April the 7th or 8th presentation. So, just as background, we're talking about how common is this. And, you know, for this slide, I just put there the end-stage kidney disease. What's end-stage kidney disease? Well, none of you want to think about this, but the definition is when the kidneys have failed entirely and you have to have dialysis 3 times a week just to stay alive, or you have to have a kidney transplant. So that's the dire end that we all want to avoid. So here are just some figures for you. In the SLIC, and you've heard me talk about the SLIC multi-ethnic inception cohort. This is a cohort from put together by 30 centers from around the world, and we were one of the founding members of SLIC to study lupus. And the incidence of lupus in the modern era, because the SLIC was started in 2000, say. So in the modern era, still 10% of lupus patients in the SLIC cohort went on to end-stage kidney disease. Remember, end-stage is dialysis or transplant. And in a recent review, meta-analysis of all the studies that have been published from around the world, 18,000 patients from all over the world, the 10-year incidence of kidney disease of end-stage kidney disease was 17%. And this is in the developed countries, not even counting those countries that haven't achieved the same level of medical care that we luckily have. So still 17%. We consider ourselves very fortunate. The UTLC is the University of Toronto lupus cohort. End-stage kidney disease, that is dialysis or transplantation, occurred only in little over 8% of our patients. And these are patients that we followed for at least 10 years. So we're doing pretty well, and we could talk at the end as to why that might be, but you see that we're dealing with a significant problem. Nobody with lupus wants to end up with dialysis or transplantation. All right, so the aim of this study was to see, well, why do people do, what happens? Why do they go on to advanced stage kidney disease? And we decided to do not the dialysis or transplant. That's too late. By then we could say we failed, right? So we took all people who had gone quite far along in their kidney disease. It was called advanced kidney disease. Let me show you what I mean by that. In kidney function, kidney disease, so if you're normal or mildly decreased, mild to moderately decreased, you still have normal function. You can still walk around for a long time. When you get to level 4, you have severely decreased renal function, and your chances of going on to kidney failure are pretty high. So what we wanted to find out is, well, why do people get even this far? Remember, we're talking generally about young women, and they should not get this kind of thing. So what are the factors that drive the development of this kind of impaired kidney function, which could eventually lead to dialysis or transplantation? Well, we've come up with 6 different things that I want to talk to you about today that we've shown in our studies, and they're really very informative and will guide our therapy for the future. So the first thing are kidney features, clinical features or the kidney biopsy class. Now, I know our lupus patients always say, well, why do you need a kidney biopsy? You get my urine, you collect my 24-hour urine, you do blood tests for kidneys. Do you need to do the kidney biopsy? Where you have to come in, have a needle stuck in your loins, and we have to explain to you the potential complications, although they're virtually non-existent. But by law, we have to tell you what the issues are. So the people sometimes are concerned that maybe this is a test that isn't necessary. Well, it is necessary. So, and I'll talk to you about that in a moment. So we took our patients from our clinic, and we diagnosed them with lupus, nephritis, whether we did a biopsy or whether we did their urine test, etc. And we had followed them for a significant period of time. These were the patients. And we ended up with 418 patients that we wanted to talk about. So of these patients, now just watch this, because this is going to help understand in the future what some of the factors are that determine long-term outcome. 50% of these patients achieved a remission within the first year. These were good patients. They took their medicine. Their disease was such, and I'll show you in a moment where it should respond. And so they did very well in the first year. 102 or 20, about 20, close to 25% of them got better either in the second year or by the third year for sure. So this is what we used to think, by the way, was the common thing, that people really didn't achieve it until they went somewhere between 2 and 3 years. But this was in the next group, 25%. A smaller percent didn't achieve a remission even after 3 years, and that's not a good story. And then we're going to talk about that. And then a few people, 8.9%, 9%, never achieved a remission. And this is where we need to plan for the future. Why? Why are there people that could never get a remission? And I'll talk to you about that in a little while. Now, remember, I showed you that these are the people that are going to get to level 4, right? They're not on dialysis yet. But of these people, right, who had this level 4, there were about 15%, 16% who went on to level 4. About 37, a little less than half of those actually later went on to end-stage kidney disease. That's dialysis or transplant. That's the 8% that I talked to you about before. So these people, once they get into that level 4, we don't want them to go any further, right? So these are the people that we want to be very diligent about. Get everybody into these better categories up here and keep patients in level 4, not let them go on to end-stage kidney disease. All right. So what are the factors? So the first factor is that kidney biopsy that I talked to you about. There are 6 different, so why do we do the biopsy? We do the biopsy because by looking at the urine, we don't know what's inside the kidney. And what we've learned is that in the kidney, there are at least 6 classes of biopsies that can be seen. Some of them are telling us, whoa, this is very advanced and the kidney is very scarred. Some of them, class 3 and 4, are going to tell us that there is a fire burning in the kidneys. The kidneys are on fire with inflammation, and you've got to do something rather quickly. You've got to put out this fire. If you go to level 5, it may be this is a damage that's damaged the structure of the kidney. Not so much the fire, but the structure. And this may require an entirely different treatment than these two in order to get the same kind of response. What do I mean by structure? So the kidney is composed of a lot of glomeruli or nephrons. A nephron consists of this glomerulus and some tubules that come off it here. The kidney has hundreds of thousands of these nephrons inside it. And what happens in these nephrons is the blood comes in, it flows in through blood vessels into these nephrons. The plasma and in the blood is filtered. The good stuff is kept and reabsorbed, and the bad stuff comes out in the urine, like the protein or the bacteria or the toxins, etc., come out in the urine. These nephrons in the kidney need to be preserved. Every time you have a kidney inflammation, some of the nephrons get damaged. And the time that you reach a level of nephron damage that actually impairs the kidney function, then you're in trouble with kidney function. So we've got to save these nephrons, right? And I told you that there are a number of ways these nephrons are affected. One, they can be on fire from the inflammation from the lupus, or they can have the antibodies from lupus that are integral to keep the function, to keep the structure of the nephron intact. And if the structure of the nephron fails, then the nephron can't do its work properly, right? So the kidney biopsies is going to tell us which one of those is it, and which drug should I use, and how long should I use them for, what dose should I use, so that when the doctor says to you, you have lupus nephritis, and we really need to do a kidney biopsy, believe them. The kidney biopsy is going to tell us how to treat you, how long to treat you, and which drugs to treat you with. A very important factor. Okay, the kidney biopsy class. The second thing is, remember I told you, our goal is to keep those nephrons alive, because as the nephrons die, the kidney loses its ability to function. So how do you keep the nephrons alive? Number one, when you start treatment, get your response quickly. The longer it takes you to get a response, the more nephrons are going to die that time. The second thing is, once you've got a response, lupus patients tend to get flare-ups of their lupus. The number of flares in the kidney will also compromise the number of nephrons. The more flares you have, the more nephrons you lose. So every time there's a flare, you've got to consider that a proportion of your nephrons will be damaged and their function lost. The next very important thing that we've really learned about recently is the urine, which we thought was so informative, can sometimes fool us. In other words, looks like the urine protein is now normal. And you say, okay, we're done. We can stop these terrible drugs. And what we have found out is that if those patients are biopsied when the urine is normal, they still have fires burning in their nephrons. And you shouldn't stop the drug too early. Even though the urine is clear, the fires are still burning. Keep the drugs going longer. And that was one of the things that really caused us big problems, because everybody wants to get off these powerful drugs because they have side effects. But if you get out too early, give up too early, then you're undoing all the good work you've done. You've put out 80% of the fire, but the 20% that's still there may cause excessive damage and undo all the good that you've already done. So those three factors that I want to talk about: get it done quickly, don't allow flares to occur, and don't be fooled by a normal urine and get off your medicine too early. And we've actually done some studies there to show this. So if you look here, in our patients with advanced kidney disease who already got on to level 4 and are really a threat to go on to level 5, you can see that their average time to complete remission was 3 years. And people who didn't go on to level 4, their average time was only 1.5 years. So it's a big difference. Don't sit around after 3/4 of a year and say, oh, I'll just give it a longer time. No, think carefully what you have to do to intensify or change your therapy, because the longer you go, the more nephrons you're going to lose. Okay, skip down here to the flares next. If you look at flares, you can see the people who had no flares at all were the people who did not advance. Now, a few people who did advance didn't have some flares, but they advanced for other reasons. But look at the people who flared twice or more in the next 5 years. You can see the people who had advanced kidney disease, 2/3 of them, 2 out of every 3 who had 2 or more flares went on to chronic kidney disease. So the next thing is get a fast remission, get enough treatment so you don't have flares. And that also means, by the way, frequent reviews. The patient needs to be seen often so that you can pick up early when there's a flare and knock it out, right? Because the more flares you have, the more nephrons you lose, and the more likely, 2/3 chance of going on to chronic kidney disease. And then the last one that I talked to you about was, well, how long did we keep people on our treatments? So you see that if people went on to chronic kidney disease, they only took their treatments for 2 years. The people who did not go on took their treatment for 4 years. Now, the dose may be slightly lower, but they were on for 4 years, even though we said their kidneys were in remission. Please remember that. So even if your doctor tells you, you're in remission, good, we're done. No, we're not done. You've got to keep on because of those silent fires, which could lead to loss of nephrons. Okay, so those here you have it in our own cohort. We've shown you those 3 factors that I talked to you about. The time it takes to get a remission. We want that to be fast. The number of flares you have over the next 5 years, you want that to be very little. And the duration you stay on your immunosuppressive therapy, we want that to be long. You follow those 3 goals that we should have, you will have a much better chance of not advancing to chronic kidney disease. Okay, so those are the 3 key things which you will have a role in contributing to by speaking with your doctor as to where you are in each of these. Now, there are a few uncommon things that happen and that have led to renal end-stage kidney disease even within a year. And these are very rare, and I'm just mentioning them to you. They're very uncommon. I'll just give you an example. Here, there are 4 different things that we saw in the biopsy that said, whoa, these people are in bigger trouble than even those other biopsies I showed you about. One of them I'll point out to you, because you all know that about 40% of patients with lupus have an antiphospholipid antibody, an antibody in your blood which makes the blood clot more easily. Okay, so if you have kidney problems like an inflamed nephron, here's that nephron again, and you have a tendency to clot, you can get a clot in the blood that's going into that nephron, and that makes the nephron die much earlier, right? So we look very carefully at the biopsy. We'll probably already know if you have that clotting factor because we study that on a regular basis. But if we didn't know it, and this shows it on the biopsy, that tells us another form of treatment that we must use. Not only put out the fire and not only maintain the structure of the nephron, but also use an anticoagulant to stop the blood from clotting. So again, it's making it a point how important biopsy is to us. It tells us really how to manage it. All right, so now if it's the kidney biopsy, those 3 factors I told you about, the duration of time to remission, the number of flares, and the duration of treatment of your flares, here is a very important final predictor of bad outcomes. Now, don't feel too guilty, but feel a little bit guilty. This has to do with patient compliance. Let me put this into perspective. In large studies done irrelevant to the disease, irrelevant to the condition, but studies which have looked at, of all the prescriptions prescribed, how many were even filled in the pharmacy? The answer is somewhere between 50 and 60%. So between 40 and 50% of people who get treatments don't even fill the prescription. And then, of course, those who fill the prescription, how many take it as prescribed? Patient compliance. So in studies of patient compliance, here's what you hear. Oh, these drugs, I read about it on Google, Dr. Google, and Dr. Google told me that they have many harmful side effects, so I can't take them. Or life gets in the way of living. I'm too distracted. I've got other things and I forget. So I'm supposed to take it twice a day, but maybe I take it once a day. Maybe I take it once every 2 days. These are the common admissions that patients make when they're confronted about being compliant or not. The other thing is, they think, well, look, I'm so good. He told me that my urine is clear and I'm feeling well. My urine isn't frothy anymore. Why do I need to keep taking this medicine? I don't think it's going to get worse if I stop it. So I stopped it. And I've shown you stopping too early leads to flare-ups and loss of nephrons, right? And then there's the very important one that is for personal reasons. And you know what people meant when they meant personal reasons? Cost. Cost. The newer drugs are so prohibitively expensive. So 50% of patients have insurance. 50% of patients don't have insurance. And if you don't have insurance, and you could for sure not afford these drugs, we're talking $20,000, $25,000 a year. I have appeared before CADIT, which is the government funding agency for people who can't afford it. I've made the point for belimumab, which we'll come to in a little while. And each time the government has remained unconvinced. So far, the government is not funding these newer drugs. And when I heard Linda speak before about advocacy, or whoever spoke about advocacy and presenting to the government the need to support drugs which are life-supporting, you couldn't be doing more important work, because compliance due to not being able to afford it should not ever be a factor. And that's what we really need to work at. So I told you, most studies are reporting a half to two-thirds of 3/4 of patients are non-adherent for one reason or another. We recently did a compliance study, and we did pill counts and people who were took them. It's amazing. Now, so you say, why did we do so well? And there are a number of reasons. Reason number one, we see our patients often, every 3 months, whether they're sick or not. The second thing is we have a lupus nurse associated with our clinic who speaks to our patients and finds out. We have pharmacy involvement to see if they can work on getting patients, describing to the patients how they can take their pills together or away from meals, not away from meals, et cetera, et cetera. If you put all of those other aids into the picture, the compliance will increase, right? So let's remove compliance as one factor leading to end-stage renal disease. Let's remove it. Make commitments among yourselves that patients will be compliant, and we will make the commitment to keep talking to the government funders to make sure that compliance can continue, can occur, because the patients will be supported in their medication needs. All right, so what did we learn? Complete remission within the first year, that protects your nephrons. Flares make it worse, for sure, so we got to prevent flares. Stay on your drugs long after remission, 3 to 5 years, to make sure that all the fire is out, and that will preserve nephrons. So I've shown you then that today we know how to do it, right? So all we have to do is get the doctor and the patient to cooperate, use the right treatments, and then the progression to end-stage kidney disease should not occur as often. All right, so how do we do this? So look, you've got a lot of very good advocates now, doctors, and I'm here, and we could talk about newer medicines. Let me put this into perspective for you. In the 50s, we had 2 drugs, Plaquenil. Hey, any drug that has lived for 70 years, from 1950 to today, must be a good drug. Plaquenil, remember that. I can't say that more important. Every patient, unless there's a major contraindication, should be on Plaquenil. And then cortisone was discovered at that time also. And, cortisone is life-saving. If you want to put out the fire, you have to use water. So cortisone is our water. It's just you don't want to use too much water, because then you get water damage, right? So cortisone's been around for a long time. Then in the 70s, we got our first immunosuppressive drugs, cyclophosphamide, azathioprine, methotrexate, and then it took us 30 years to get our next immunosuppressive drug, mycophenolate. These are very important drugs, but these are atom bombs. What I mean by that is They go in and knock out your bad cell, but they don't know the difference between a bad cell and a good cell. So all of these drugs knock out all cells, right? So we have to be very careful, make sure that we don't knock out too many of our good cells. However, they made a big difference. They improved longevity in systemic lupus by many, many years. So even though they were atom bombs, and I don't advocate atom bombs in real life, but even though they are sort of multi-potential, they have been very important. So it took there from 1950 to 2010, so 60 years after the first drug, we had our first biologic, and it is not an atom bomb. It goes after one cell type. It's the CD20. It's the B cell, which makes antibodies. And we know in lupus, one of the major issues is the lupus B cells make too many antibodies, too many of the bad antibodies. So with that drug, we're addressing only the cells that make those antibodies. Now, they also knock out a few other antibodies, but it's not like the atom bomb. They don't kill the whole immune system. They're targeted, okay? So that was a major breakthrough, and that's the one I told you the government still doesn't fund for people who can't afford it, even though it's been around since 2010. If you think I'm talking loud now, I scream when I talk to those funders. It's unconscionable. The next study came out was the same drug, belimumab, which you may know as Benlysta, in 2021, actually, was passed for lupus nephritis. So we finally have a drug, another drug for lupus nephritis. And 3 other drugs appeared at the same time. Anifrolumab, which is a targeted drug against a specific target in lupus, the interferon molecule. It's a drug which now has been approved by the US FDA and is before the Canadian Health Canada. I think will soon be approved, right? So this is the second biologic, and it's targeted against one molecule. Now, it's a molecule which drives, it's sort of the gas of the immune response, but it's a targeted molecule. Then there are 2 other molecules that are now in, that the voclosporin actually is before the American FDA and may be approved sometime this year. And I think is also being considered by Health Canada or will soon. This drug, by the way, works on the structure. Remember I told you the structure of the nephron in some cases gets affected. This one works on improving the structure of the nephron. So it's a very important drug and may be able to be combined with one of the other drugs. The final one is obinutuzumab, which is a drug. Some of you may have heard the word rituximab. It was a drug which was used in lupus. It's also a drug which knocks out the B cells. Rituximab was done in a trial which was negative. But a lot of doctors said, I don't care if the drug was negative, the trial was negative. We know it works in some patients, and it does work in some patients. Obinutuzumab is rituximab on steroids. It's much more powerful than rituximab. Doesn't seem to have any increased side effects. And when it comes out, maybe more, just like rituximab is used by some people, this drug will probably be used by even more people because it's much stronger than rituximab is. So there are 3 new drugs on the horizon: the anifrolumab, the voclosporin, and the obinutuzumab. They all have big, fancy, long names. You'll have to learn how to say them. But these 3 drugs, I think, in the next year or 2 will become available on the market. So nothing for 50 years. And now all of a sudden, in 2 years, we're going to get 3 new drugs. That's very encouraging. You know, And how are we going to use these now? Well, we know, for instance, that mycophenolate really works on this in lupus, but it takes a while. It takes 6 months or a year before you see anything. We know that voclosporin, this drug down here, you see results in a month, 3 or 4 weeks. It is possible that in the future, we might say, let's start voclosporin, and in a few weeks, once it's had its effect, we'll put in the mycophenolate or one of the others, keep the two together for a while, then take away the voclosporin and keep them on mycophenolate. What I'm telling you is, it looks like we're finally going to have the possibility of multiple drug treatment. Now, don't say, oh no, multiple drug treatment. Listen, if you have high blood pressure, you're taking 3 pills. If you have diabetes, you're taking 2 or 3 pills. If you have multiple sclerosis, you're taking 2 or 3 pills. You try to hit the targets from many different entrances. So having a number of drugs is a good thing, not a bad thing. And the drugs can either be used sequentially, as I just described to you, start with one, then add the other one, or it may even be wise to start 2 together. For instance, we know that belimumab takes about 2 to 3 months to work. You could start mycophenolate and belimumab together, knowing that this one isn't going to work for 3 months. This one will start to work very quickly, right? And then you may eventually end up staying on this one, belimumab, because it works for a long period of time, and weaning yourself off this one. What I'm telling us now is that in the future, it really looks much brighter because we're going to have more drugs. Look, 4 drugs in 1 year as opposed to 3 drugs in 50 years. We're moving along. And we may use them either in combination right off the bat, or we may use them sequentially, one after another. All of those bode very well for lupus. So, I've shown you why we go on to bad kidney disease in the end. I've shown you what we have to do to prevent it. And now I'm showing you it looks like we're even going to have more drugs available than we've had in the past. So I think we're getting there. I think things are closer now. For me, I'm very optimistic. And I think you want to be involved in these studies early, know about them. And it's really a delight to be able to talk to you and talk to you even before I'm going to speak to the Lupus Academy in 2 weeks. So keep it a secret. Thank you.
Thank you, Dr. Urowitz, for that very informative speech, presentation. There's a lot of great information in there, and thank you for ending on a message of hope. If anybody has any questions for Dr. Urowitz, could you please put them in the chat, or I'm sorry, in the Q&A. Sandra will be moderating, and we'll pass those questions on to Dr. Urowitz. So please enter your questions if you have any for Dr. Urowitz.
There was just one question earlier. Someone wanted to know about the transition program that was spoken about at Toronto Western and Mount Sinai.
Right.
How to get referral, or how you get involved with the program.
So the transition program is generally the bulk of the patients come from hospital for sick kids. And you should know that there are 2 clinics now that are accepting these patients. The one at the Western has really been amplified very dramatically. And so it's actually being administered by Dr. Zahi Tuma, who's wonderful, by the way. And it's attended by Dr. Silverman and I think Dr. Levy. The sick kids people even actually come into the clinic for a year, so the patients feel the transition is the 2 teams meeting together, the pediatric team, the adult team, and then the patient transitions smoothly.
Okay, one other question. Does very dark urine, dark yellow, indicate kidney failure?
No. So the color of the urine is a difficult thing unless it's red. You know, if it's red, then it means there's some bleeding. You have to look into that. Otherwise, the only other, sometime when there's a tremendous amount of protein in the urine is very frothy. Now, I hate saying that to people because they say, oh, I have frothy urine. We all have a little bit of frothy urine, so don't get excited. But with very high protein loss, you know, if the kidney is leaking lots of protein, the urine can become very frothy, more than usual. Other than that, you know, color is very difficult because color can be concentration, you didn't drink enough, could be what you ate, can increase the color. By the way, beets, you know, beets can give you if you eat beets, you can get a reddish, pinkish discoloration in the urine and in the stool. So your diet can have an effect. So don't put too much emphasis other than very frothy or dark red.
Okay, thank you. That is it for now. If there's anything later on, I will actually, oh, okay, just a couple of compliments. Thank you very much, Dr. Urowitz. Thank you for speaking and explaining in a way we understand. So those are a few just comment. If anything else comes along, if we're not able to answer it today, I will make sure I pass it on to Dr. Urowitz and we will get back to you. There was a comment, nothing to do with Dr. Urowitz, but I will just mention it because someone mentioned it. And I just want to mention our dance program that we have, Linda. So someone thought they really missed the music and dancing from the Italian dinner. Perhaps a virtual dancing exercise element is virtual again. So for it is an anonymous, but for those who are interested in dance, please be reminded our future young doctor, Emma Neri, is doing an amazing job with dance and medicine bi-weekly. That's being held later today at 4 p.m. So if you are interested in dancing, please join us for our bi-weekly section, Dance and Music by Emma. Thank you.
So thank you, Sandra. And